Thank you for that introduction, Dr. Zambarini, and good morning to everyone. Hope everyone can hear me. I have a bone to pick with you for putting me after Dr. Trudy Smith on her topic. So unfortunately, I'm not that humorous. So my topic, as mentioned, I'll be talking about the contraception choices in patients that are at increased risk of thrombosis. Okay, so quite a lot of women are using the pill, about 150 million. And the majority of the women are using the combined hormonal contraceptive, which is the COCs. And with such large numbers of women, it's even more important that you reduce the risk of side effects, because even if it's low, it affects a large number of women. And contraceptives, they're usually administered to women that are of reproductive age, so they're young, very few comorbidities if present, so really you should minimize the side effects. I'm going to be mostly focusing on venous thromboembolism, and it does cause rare, but it's potentially preventable cause of death in these women, and most of it is due to the combined hormonal contraceptives. But what is more important is that pregnancy and the postpartum period actually cause a higher risk of VTE in these patients. And the most common sites of thrombosis, and in these patients that have high estrogen levels, is actually similar to any other VTE, so it will be the deep veins of the legs and the pulmonary veins. And CHC use has also been associated with unusual sites of thrombosis, so it will be the cerebral venous sinus thrombosis. The overall risk is still very low because these are very rare. So although VTEs are more common than arterial thrombosis is also important because it's associated with a higher morbidity and mortality in these patients. And the pathogenesis of this arterial thrombosis is different in patients with VTE, because typically it's usually caused by atherosclerosis, but in these patients it's due to a hypercoagulated state. Okay, just to make it more about hematology, I thought I should just look at the coagulation cascade, because it will help better understand how high estrogen levels then lead to an increased risk of thrombosis. So I'll simplify it and start at the beginning of where does VTE start. So it usually starts with, let me say, vascular injury, but not everything. COVID has told us or has made us aware now that even immune cells, they do express procoagulant factors. So I'll simplify and say it starts with vascular injury. So we have primary hemostasis. I don't have a pointer here, but it starts with the platelets. So when they
Yeah, cool. Yeah.
So once that primary platelet plug is formed, then the procoagulant proteins then they get activated to form the fibrin, which is the endpoint, to make that clot much stronger so that it doesn't dissolve easily. So we've got the extrinsic pathway, and which starts with the tissue factor, and we've got the contact pathway. When one factor is activated, it activates the next, but the end goal is thrombin generation, which will then cleave fibrinogen to fibrin, and then we've got the strong clot. What I wanted to focus more on now, because I'll be talking about it, is what mechanisms are there to stop this process. So we've got the tissue factor pathway inhibitor that stops tissue factor, and we've got antithrombin, as the name suggests, it inhibits thrombin, And there's also the protein C pathway. Protein C, together with the cofactor protein S, they then inactivate factor 5, which is an important cofactor in this pathway. And lastly, there's the fibrinolytic pathway to dissolve the clot once that injury has been sealed. The second image, it's just to highlight the important role of the Willebrand factor. It's this one here. It acts as a bridge between the subendothelium and the platelets. And the platelets also provide the phospholipid surface for the procoagulant proteins to bind. And it's very important in estrogen-related VTE. So for VTEs in general, there's usually not one factor. It's a multi-causal disease caused by interactions between a number of risk factors that are additive. And these clinical risk factors are graded. There are some that are strong and result in the VTE without the presence of any other risk factors. So that would be a patient that has had a hip or knee replacement. And today we're talking about contraception, so they fall into the moderate risk factors. But in most of the patients, there's usually a number of risk factors that play a role in VTE formation. Okay, so what is the pathogenesis then of this combined hormonal contraceptive related VTE? So there's a combination of things. There's an increase in the procoagulant proteins combined with a decrease in anticoagulant proteins. So I'll start with the increase in the clotting factors. So estrogen is known to cause an increase in von Willebrand factor levels by directly stimulating the endothelial cells. I've already shown you the role of von Willebrand factor. And secondly, these combined hormonal contraceptives, they also increase the procoagulant proteins such as your prothrombin, factor 7, important in the extrinsic pathway, factor 8, which is an important cofactor in the pathway, 10, and also fibrinogen. And the decrease in the anticoagulant proteins, it's mainly the tissue factor pathway inhibitor, which I've mentioned. It inhibits the extrinsic pathway, and antithrombin that inhibits thrombin. Secondly, there are studies showing that these patients have an increase in protein C, which is one of the naturally occurring anticoagulants. But this increase, at the same time, when there's an increase in protein C, there's an increase in inhibitors, so it balances out. These patients develop an activated protein resistance state, which is similar to factor 5 laden mutation. But it's different in the factor 5 laden mutation because the problem with that is that the factor 5 has developed a mutation that makes it resistant to being cleaved by the protein C. Lastly, there's a pronounced decrease in the cofactor of protein C, which is the protein S antigen. So all of this together, they tilt this hemostatic balance into a prothrombotic state. Why do we make a fuss about VTEs? I absolutely love this triangle. Once a patient has a VTE, there's an increased risk of recurrence, and it depends. So on top, most of the patients we treat short term, so that will be 3 to 6 months. So if a patient, this is just a general now, not in patients on CSC. If a patient has a VTE due to a major transient risk factor, so that will be the hip and knee replacement, the risk of recurrence is very low. It's 1% in 1 year and 3% in 5 years. So you can safely stop anticoagulation in those patients. But the group that we're talking about now is a little bit tricky because it has an intermediate risk of recurrence. So the women with VTE, for example, that develop VTE on hormones. So they've got a 1 year risk of recurrence of 5% and a 5 year risk of 15%. So although it is recommended to treat this patient short-term, 6 months anticoagulation and then stop, there are other factors that may make one treat for longer. For example, if the patient has a history of an inherited thrombophilia or strong thrombophilia, or the patient has an antiphospholipid syndrome. So just one slide on arterial thrombosis, because it does happen with combined hormonal contraceptives, although rare. There is evidence to suggest that the risk of both a myocardial infarction and thrombotic strokes due to estrogen are increased, but the absolute risk again remains low because this is very rare. And one needs to take into account other risk factors such as hypertension that further increase this risk. And as mentioned in the previous talk about the progestogen-only contraceptives, they would be safe in this group as they are shown to not increase this risk further. Okay, so in these women, for example, that we are either considering for combined hormonal contraceptives, what are those factors that are associated with the high risk of thrombosis? As I've mentioned, a previous history of VTE is important, strong thrombophilia, so this would be a homozygous factor 5 laden or doubly heterozygous, either you have a heterozygous factor 5 laden combined with a prothrombin gene mutation, severe deficiencies of protein C, S, antithrombin, and the acquired antiphospholipid syndrome. Or if a patient has a strong family history of a VTE without any genetic mutation identified, those patients are at high risk. The postpartum period, as previously mentioned, SLE patients that have a positive or even unknown antiphospholipid antibodies, and then other cardiovascular disease risk factors, as shown. So just to touch quickly on thrombophilia testing, because we are often consulted to work up patients that have had VTEs. So really, fatal VTE is very rare, and there was a study done, and this investigator concluded that you have to screen more than 1 million CHC users for thrombophilia to at least prevent 2 oral contraceptive associated deaths. As a result, this testing is not recommended for thrombophilia. Thrombophilia screening is not recommended in patients prior to starting oral contraceptives. However, this does not exclude taking a clinical history. I mean, those patients where there's a history, family history of recurrent DVTs, as I've mentioned, those patients will be at high risk and then could be tested. Okay. So getting into the thrombosis, when do we usually see this thrombosis? So the increased risk is within the first 6 months up to a year of using combined oral contraceptives, and it's thought to retain to baseline within 3 months of stopping the contraception. And I think Dr. Trudy Smith, touched on this. So does the dose of estrogen affect VTE rates? So there are no randomized control studies on this. It's case controls and cohort studies. And it was really difficult to determine whether it's the estrogen dose or the progesterone component that is increasing the risk of VTE, because the investigators have no control on what's the combination that the patient is taking. So you might be able to look at the same dose, but you find out these patients are on different progesterone component combined with the estradiol. However, despite this limitation, there is evidence to suggest that the increased estrogen dose, which is more than 50 microgram, is associated with high risk of VTE, and currently these contraceptives are not used. And also the fact that if you reduce the dose to less than 50, the VTE incidence also decreases. Okay. Touch on the progestogen type, but does it really contribute to the VTE risk? Again, for the same reasons that I've mentioned for assessing the estrogen dose, difficult because you can't control you can't control what the patient is taking. It's not a randomized control study. However, in the appropriately selected patient, the choice of a contraceptive method, it does not need to be made based on the type of progestin. So it doesn't really make a difference. Then does the route of administration contribute to the VTE risk? So what the evidence is showing is that there's an increased risk of thrombosis with all the routes of administration of CHCs. So that will include your oral contraceptives, the vaginal ring, and the transdermal patch that was mentioned. So if there's a contraindication to use the COCs based on increased risk of VTE, then this should also apply to the other methods. Okay, so what are then the preferred contraceptions? So there's non-hormonal and hormonal, and the non-hormonals are mentioned there. Dr. Smith has mentioned them. And then the hormonal would be the Mirena, the Intanon, and the progestogen only pill. I've left one out for a reason. I'll discuss therefore in the next 2 slides that I think is important. So is there then evidence to say that these progesterone-only contraceptives are safe in this context? Evidence does show that there's no increased risk of VTEs with progesterone-only formulations, including the ones I've already mentioned. So what about DEPO? The data is really less clear. There was a meta-analysis based on 2 studies that found a 2-fold increased risk of thrombosis with these injectables. However, there were so many confounding factors that the results were unreliable or weak. Therefore, DEPO in women at risk of VTE is allowed, and it's classified as category 2, which means that the advantages of using DEPO outweigh this theoretical risk of increased VTEs. So it can be safely used. Okay, so this is just the list of all the available contraceptives, hormonal contraceptives, and with their risk of thrombosis from highest up to the lowest. So high is the combined hormonal contraceptives, and the lower risk is the progesterone-only contraceptives. Okay, I thought I should just mention SLE on its own. We are well aware that SLE increases the risk of both arterial and venous thrombosis compared with the general population. And this risk is further increased by the presence of an antiphospholipid syndrome. So for these patients, testing for the antiphospholipid syndrome or antibodies is recommended before starting combined hormonal contraceptives, and it will then be contraindicated in those women that have a positive antibody. And in those patients that do not have a persistently positive APL antibodies, it can be used provided that there are no other cardiovascular disease risk factors. Okay. So what happens to those patients that have developed a DVT on an estrogen? Can you then use it at a later stage once you've treated the DVT? So those patients that have a history of thrombosis are at an increased risk of another clot. So estrogen therapy or any future estrogen therapy would be contraindicated in this group. Okay. So far, I spoke about patients at high risk of thrombosis that were not anticoagulated. But now, what about those that are on therapeutic anticoagulation? Because their risk of thrombosis is actually lowered by the anticoagulant therapy. And also, if these patients were on combined hormonal contraceptive, it would really assist with the heavy menstrual bleeding that is usually associated with anticoagulation. There was a study that analyzed data from one of the biggest VTE and PE trials, and it concluded that the CHCs really do not increase the risk of thrombosis in the women who were on therapeutic anticoagulation, and use in this group can be considered on a case-by-case basis. For example, if a patient has polycystic ovarian syndrome and really has to use a CHC to further help with the symptoms. Okay, so what about those patients that have had a previous VTE unrelated to combined hormonal contraceptives? Can you then use the COCs at a later stage? So generally, the risk of recurrent VTE will depend on whether the initial thrombosis was due to a permanent or a transient risk factor. So if there's someone that has a history of a single episode of a VTE associated with a non-recurring risk factor, may not technically be at an increased risk of recurrence. And they do say that a CHC may be considered if no other method is available, but there's always another method available, and they classified it as category 3. So the final recommendation is rather use another method and not a CHC. Okay, so surgery, we know that VTE is a major cause of fatalities that are associated with surgical procedures, including gynecological procedures. And clotting factors really normalize about 4 to 6 weeks after stopping combined hormonal contraceptives. So the use would be contraindicated in those patients that are undergoing major surgery, where one anticipates that there might be prolonged immobilizations. However, if patients are expected to be ambulatory after the surgery, then there's no reason to stop combined hormonal contraceptives. Okay, so lastly, I just thought I should provide a simplified algorithm on how to deal with this patient, or how to approach this patient. So the initial question should be, or would be, does the patient have a history of VTE? Because we know right off the bat that that patient has an increased risk of a recurrence. So if the patient has a history of a VTE, then the next question would be, is the patient on long-term anticoagulation? If that patient is not on long-term anticoagulation, then you need to avoid CHC. So history of a VTE, not a long-term anticoagulation, it's not recommended to use CHC. However, if that patient has had a VTE and is on anticoagulation, it can then be considered, provided there's no other option and they really have to use the CHC. If the patient doesn't have a history of a VTE, then you have to look for other risk factors. And if those are not present, then CHCs can be safely considered. But if there's other risk factors besides a previous history of activity, then it is recommended to avoid CHC. So that is my last slide, and thank you for listening.